inviting me to speak, so the title was already disclosed. I do have some disclosures, so I'm a consultant for Exact Sciences and consultant in Speakers Bureau for Myriad Genetics. So the objectives of this talk are to go over the new screening guidelines, talk a little bit about some research behind the guidelines, review hereditary colorectal cancer syndromes, which have increased risk in their own set of guidelines, including Lynch syndrome, and then talk a little bit about some of the research we've been doing here in Louisiana. So I'm going to start with a few questions. Question number one. Hopefully you'll be able to answer these questions, or at the very least at the end of the talk. A 68-year-old male presents with rectal bleeding and is found to have an ascending colon mass on colonoscopy with path showing adenocarcinoma. There's no family history of cancer. What do you recommend? A, first-degree relatives have colonoscopy at age 40 and every 5 years afterwards. B, proceed with surgery with no additional testing given age and lack of family history. C, recommend MSI, microsatellite instability testing on a colonoscopy biopsy specimen. D, recommend MSI testing on a surgical specimen. Question two, we'll answer these at the end. Question two, which of the following best describes the epidemiology of colon cancer in recent decades for patients 55 years old and over, like our patient in the previous question? One, rates in those 55 years and older are increasing, as are rates in those younger. Rates in those 55 years and older are decreasing, as are rates in those under 55. C, rates in those 55 and older are increasing, and rates in those under 55 are decreasing. Or D, rates in those 55 years and older are decreasing, and rates in those under 55 are increasing. The last question. A 60-year-old man ends up having an MSI high tumor and has germline testing confirming Lynch syndrome, which is true concerning Lynch syndrome. Recent studies have shown no association between this syndrome and prostate cancer. B, about 1 in 279 people in the U.S. carry a Lynch syndrome mutation, and most are aware that they are carriers. C, the lifetime risk of colon cancer in Lynch is about 30%. And D, the 4 main genes associated with Lynch are MLH1, MSH2, MSH6, and PMS2. So those questions look challenging. I don't know if they do or not. After this talk, we should be able to answer those questions pretty easily. So just some colorectal cancer statistics. It's the third most common cancer in both men and women. And the American Cancer Society estimates that in 2020, there are going to be about 106,000 new cases of colon cancer in the U.S. and 43,000 cases of rectal cancer. So that's a major burden. Colorectal cancer is the third leading cause of cancer death in both men and women, and it's the second leading cause of death when you combine men and women. There are about 50,000 deaths from colorectal cancer each year in the United States. Importantly, screening can save more than half of these people, so that's why it's so important to get the message out there about the importance of screening. About 1 in 3 adults aged 50 to 75 are not screened currently. So that's about 23 million adults. So these people are at risk for colorectal cancer and advanced cancer because they're not getting screened. Some of the reasons for not being screened include lack of insurance. People may have insurance, but they may not feel that screening, quote unquote, applies to them. And importantly, there may be no doctor recommendation. Unfortunately, that's an important cause of people not being screened. Colorectal cancer in Louisiana specifically, I'm not sure if people are aware of this, but this is one of the hotbeds for colorectal cancer in the United States. We have one of the highest incidence rates and mortality rates in the country, and unfortunately screening rates in this state are suboptimal. So in 2014, those are the most recent statistics we have. Well, I think they were just updated about a month ago. The screening rate was about 66%, which ranks us 34th out of 50 in the US. Number one, the first rank would be the highest screening rate. So not horrible, we're not last, but we could definitely do a lot better. This is a map of Louisiana showing areas with disproportionately low screening rates. So these areas in red are where screening rates are below 45%, so that's pretty low. You can see Claiborne Parish, Iberville, St. Bernard, and then you can see here, kind of in the New Orleans area, we're doing fairly well, but again, we could definitely do better. This is a map showing SEER incidence rates. So these are colorectal cancer incidence rates per 100,000 of the population. And you can see here in red are areas where the rates are disproportionately high compared to the rest of the United States. And Louisiana specifically, you can see we have the 4th highest incidence rate in the US. And when you look at the African American population, Again, red in this southern area, and we have the third highest incidence rates in the United States. This is a map of Louisiana in which we did geospatial analysis of the Louisiana Tumor Registry. I'm not sure if you're familiar with the Louisiana Tumor Registry, but it's a wonderful resource here in Louisiana. It's one of the top 3 cancer registries in the United States. It's funded by the NCI and the CDC, and we're very lucky to have this registry in this state. And what we can see here is that there's a disproportionately high rate of colorectal cancer in the Louisiana Acadian parishes. And I was involved in a study that identified these high rates in this region. And the leading hypothesis now is that there may be a founder effect for Lynch syndrome. So a founder effect being kind of a magnification of a genetic etiology. And we're currently working to do genetic testing in that region to try and identify any Lynch mutations or mutations for other types of genetic syndromes. This is just information on incidence rates from the paper that we published in 2015 on these colorectal cancer rates in this Acadian region. And you can see in this Acadian 9 region, which is kind of like the most highly concentrated Acadian parish region based on French ancestry data and French census language data from about 20 years ago. You can see that the incidence rates here, about 56 per 100,000, are much higher than US rates and even higher than Louisiana as a state as a whole. And when you look at white males, you can see that the incidence rate was about 73 per 100,000 in this Acadian 9 region, which makes it the highest rate of colorectal cancer disproportionately in the United States. So this Acadian region has some of the highest rates of colorectal cancer in the United States. And again, the concern is that there may be a founder effect in that region. In terms of mortality, you can see that Louisiana has the 3rd highest mortality for colorectal cancer in the United States. So again, this just highlights that this is Louisiana as a whole, very high rates, disproportionately low screening rates, and then within Louisiana, very, very high rates in this Acadian region. So colorectal cancer risk factors in general, so alcohol use, smoking, possibly red meat consumption, inflammatory bowel disease like ulcerative colitis or even Crohn's disease if it affects a significant amount of the colonic mucosa, obesity and physical activity. These are some of the main ones that you'll see out there. Family history is a really important risk factor for colorectal cancer. So if you have a first-degree relative with colorectal cancer, so that means a parent, sibling, or offspring, then you have 2 to 3 times the risk of developing colorectal cancer compared to the general population. So it's really important to take a cancer family history because we don't want to miss these patients, because a lot of them are going to require earlier screening. Another thing I want to make a point about, the paper I think you have there is something that we just published in the American Journal of Gastroenterology last week, and it highlights the importance of an advanced colon polyp being a risk factor for colorectal cancer in relatives. So an advanced colorectal polyp is a polyp that's 1 centimeter in size or bigger, histology that shows villus changes or high-grade dysplasia. So if somebody comes in and sees you and they say, oh, my parent had this large polyp, they are almost at the same risk for colorectal cancer as if that person the family member actually had colorectal cancer. So we cannot downplay the risk of advanced colorectal polyps, and that's why I wanted to hand that paper out to everybody. So this is the paper, Advanced Colorectal Polyps on Colonoscopy, a trigger for earlier screening of family members. So this is, we think this is important, and this is an underappreciated risk factor for colorectal cancer. So some protective factors for colorectal cancer: high fiber diet, whole grains, fruits and vegetables, dairy products, and calcium, and probably really importantly would be getting screened on time. That's a really important protective factor, as would be knowing your family history so that you get screened at an earlier age if it's indicated. So colorectal cancer screening in 2020, where are we at? So the average risk population in general traditionally has been told to get screened at age 50. So that means no symptoms, no family history, average risk. Multiple societies recommend screening the African American population at age 45, however, because there's higher incidence, earlier onset colorectal cancer, and higher mortality in this patient group. So that 45, I think, is pretty much accepted for the African American population. The American Cancer Society, I'm sure you heard about this about 2 years ago, came up with a recommendation that everybody in the United States should be screened for colorectal cancer at age 45. So that was an important change, but not all of the guidelines agree on this. And again, symptoms, family history, etc. may prompt earlier testing. So that would be called diagnostic testing, not screening. Once you have blood in your stool or family history, you're not really talking about screening anymore, you're talking about diagnostic testing. So these are the kind of the main guidelines that you may see floating out there. The U.S. MultiSociety Task Force on Colorectal Cancer. This is like our GI societies, the ACG, the AGA, ASGE, then the American Cancer Society, then the U.S. Preventative Services Task Force. This group has, as you know, has a lot of power to determine insurance reimbursements for earlier screening and things like that. So these all kind of vary on what their recommendations are. So the U.S. MultiSociety Task Force on Colorectal Cancer, I do want to go a little bit through this. These are the guidelines that a lot of us follow. Dr. Marino, any other GI doctors in here maybe focusing on these. So if you're average risk, again, no symptoms, no family history, this set of guidelines recommends getting screened at 50. If you're African American, it recommends getting screened at 45. And their quote-unquote first-tier tests would include colonoscopy and FIT. And they specifically state that you should offer colonoscopy first, and then if the patient declines, then they can be offered FIT testing. And as a GI doctor, I certainly agree with that. I think colonoscopy is the best test. But realistically speaking, some people may not want a colonoscopy. But again, as a GI doctor that does these all day, I'm certainly a proponent of colonoscopy. The second tier tests, according to this guideline, includes CT colonography, which is like a CT scan of your colon, FIT fecal DNA every 3 years, or a flex sig. This obviously a flex sig, you're not going to be able to see the proximal colon, so I'm not a big fan of that. With regards to family history, according to the USMSTF, if you have a family history of colorectal cancer or an advanced adenoma in a first-degree relative under age 60 or 2 first-degree relatives at any age, you get colonoscopy 10 years before the age of diagnosis of the youngest affected relative or age 40, whichever comes first. And then you have to repeat it every 5 years. This is why it's so critical to know the family history, not just the family history of colorectal cancer, but of advanced adenomas. Again, which is why I handed that paper out to everybody. If you have a single first-degree relative diagnosed at greater than 60 with colorectal cancer or an advanced adenoma, you get screened at 40, but then you can generally repeat this in 10 years, assuming it's normal. But again, family history of colorectal cancer or an advanced adenoma. If the relative is of any age, you're going to get earlier screening. So you need to recommend that to your patients. And as GI doctors, and I'm going to try to make the point in this paper, if we're doing a colonoscopy and we find an advanced polyp, I think it's on us to tell the person that we just scoped to tell their family members that they need to get screened earlier. So we need to counsel them to do that. We can't really bypass the person we scoped and go tell the family member ourselves, but we can counsel the person that we just scoped and tell them, hey, listen, we found this advanced polyp. You need to tell your kids, your brothers and sisters, etc., that they need to get screened at 40. So I think that's an important thing that we could be doing. So some of the stool-based tests you may be seeing out there compared to colonoscopy, they have lower sensitivity and specificity. So for example, FIT, fecal immunochemical testing, sensitivity for colorectal cancer is 73 to 88%, and specificity is 91 to 95%. FIT DNA, that sensitivity is about 92%, and the specificity is about 84%. But if you start, this is for colorectal cancer, but if you start talking about polyps, then obviously the sensitivity is significantly lower. So keep that in mind with stool-based testing. So early onset colorectal cancer, I want to start talking about this a little bit. There's declining incidence and mortality in older patients, but there's rising incidence and mortality in younger patients. Unfortunately, these patients often present with advanced stage disease. So the American Cancer Society versus the USMSTF on early onset colorectal cancer, these are some statements I want to read. So the ACS, the American Cancer Society, recommends that adults age 45 years or older with an average risk of colorectal cancer, again, no symptoms, no family history, undergo regular screening with either a high sensitivity stool-based test or a structural visual examination like a colonoscopy. depending on patient preference and test availability. So they recommend 45. The US MSTF says colorectal cancer incidence is rising in persons under age 50, and thorough diagnostic evaluation of young persons with suspected colorectal bleeding is recommended. So the US MSTF at this time does not recommend average risk screening at 45 unless you're African American, but they've raised the point that symptoms need to be taken very seriously. So these are just these differing guidelines. This was a pretty important paper that came out, I think, 2 years ago in the Journal of the National Cancer Institute, written by Rebecca Siegel, who's an epidemiologist at the American Cancer Society. And I don't know if you've seen these slides before, but what it shows is, this is calendar year on the bottom, and this is incidence rates. And you can see each block is a different age group. So these are 20 to 29-year-olds, 30 to 39, 40 to 49, and this is for colon cancer, not rectal cancer, colon cancer. And you can see that in 20 to 29-year-olds, there's this uptick in colorectal cancer over the past few decades. Same thing for 30 to 39, 40 to 49 going up, 50 to 54 kind of went down, coming up a little bit now. But importantly, you can see in older groups, the rates are going down. And in rectal cancer, it's almost more striking here. So 20 to 29-year-olds increasing every year. It's called annual percent change. It's the percent change in incidence rate every calendar year. And again, 30 to 39 going up, 40 to 49 going up, 50 to 54 going up, and then 55 to 59 down, and older patients down. So this is why in the media they're talking about the importance of recognizing early onset colorectal cancer, because the rates are going up substantially. So this is an important topic. And this was written in a paper in JAMA Surgery in 2015, and these authors said, by 2030, 10.9% of all colon cancer and 22.9% of all rectal cancers will be diagnosed in patients younger than the screening age, compared to 4.8% and 9.5% respectively in 2010. So this just highlights this really incredible burden of early onset colorectal cancer that we've been seeing in recent decades. So what's the cause of early onset colorectal cancer? People have postulated about this, but no one's really quite sure exactly what the reason is. It could be due to rising obesity, sedentary lifestyles, diets with high glycemic loads, and in fact, a Western high-fat, low-fiber diet can cause colonic inflammation and colonic mucosal proliferation in just 2 weeks. So these may be kind of synergistically playing a role in early onset colorectal cancer, but no one really knows for sure. So this is a paper that we just published in JAMA Network Open on Friday, which has received considerable attention, and it's entitled Trends and Incidence of Early Onset Colorectal Cancer in the US Among Those Approaching Screening Age. So what we did is that if you look at incidence rate studies in the past, most of them kind of pooled groups together, like 30 to 39-year-olds, 40 to 49, 50 to 59. They kind of pooled all these people together. And they basically said that in 45 to 49-year-olds compared to 50 to 54-year-olds, the colorectal cancer incidence rates are much lower. So that's been used as a rationale to not screen under age 50. So what we ended up doing is we ended up doing a high-definition SEER incidence rate analysis in 1-year age increments, as opposed to these age blocks. And what we specifically wanted to see is we wanted to see what happens at age 49 to 50. Because at age 50, we start screening, but at age 49 and younger, we're not really doing screening. So we wanted to see if there was going to be a steep increase in incidence rates from 49 to 50, and if there was, that would suggest, and if they were advanced stage, that would suggest that these cancers have been smoldering along in people in their mid to late 40s for years, and they're not reflected in incidence rates, like SEER-reported incidence rates. So that would make the statement that, oh, if the rates in 45 to 49-year-olds are much lower than 50 to 54-year-olds, we don't need to screen them. So that would kind of throw that out the window, because there are all these, our hypothesis is that if there's this high incidence rate increase from 49 to 50, that means there's this undetected burden in people that are between 45 and 49 that haven't been diagnosed yet because they're not subject to screening like people that are 50 and older. So what we ended up finding is that there is a steep incidence rate increase from 49 to 50, and in fact it's 46%. So that's a dramatic increase. And we think that this is because people at age 50, so here you can see this is the yearly age analysis that we did, and this is incidence rates. And kind of we pooled all these patients from 2000 and 2015, and we had 170,000 cases. So we think that this steep incidence rate increase of 46% basically means that all of these people here between 45 and 49, maybe even younger, are walking around with asymptomatic cancers that are suddenly detected when they undergo screening. And that's bad, right? Because we don't want to find cancers on a screening test. We want to prevent cancer, right? We want to take out polyps. Or at the very least, we want to take out in situ polyps, which have really no chance of spreading. But that's not at all what we found. And when we did stage stratification, we found that the steepest increases were in colorectal cancer from age 49 to 50 were actually in localized and regional stage cancers. So even localized cancers, those were, for the most part, unless it's like what's called a malignant polyp that's pedunculated that we may be able to get out with a colonoscopy, most of those localized cancers are going to require a surgical resection, which is not, some people will be like, oh yeah, well at least it doesn't spread. But that's a huge deal for somebody that's 50 years old to undergo, anybody for that matter, to undergo surgical resection. And there's also an 11% mortality associated with that. And then obviously regional stage cancers, which increase substantially as well, they may require radiation and chemotherapy. So we do not want to be finding these things on screening colonoscopy.
Excuse me,
Yeah.
11% mortality with the surgical resection?
There's an 11% mortality according to the American Cancer Society for localized colorectal cancer. So
Not as a result of surgery.
No, not from the surgery. No, just in general. No, I didn't mean that. Yeah, I didn't mean the operative mortality. I meant mortality in general, from the cancer. Colorectal cancer specific mortality, not from the operation. So summary, so what is this age 45 to 50?